Right. Good evening, one and all. Sorry for the small technical delay. Let me present the uh, minutes of the last general body meeting and activities for the previous month. For last general body meeting, which was on Saturday, 16th of January, the meeting was presided by Dr. Joy Manjila and there was addressed by Dr. Jay Chiman, who is the Joint Secretary of IMA University. Secretary presented the minutes and activity report. The minutes was passed to the general body. Scientific session was conducted by Athraya Specialty Hospital, Thrissur. Professor Dr. Andrews, Principal of Medical College, Thrissur, chaired the session. Professor Dr. Madhusudan sir conducted Meet the Professor 20 most important points in clinical urology, and there was a second session on management of headache in clinical practice by Dr. V.T. Haridas, and the third session by Dr. Ram Kumar on red flag signs in headache management. This was followed by a panel discussion. Then we had the IMA AMS Thrissur CME series on post-COVID-19 sick leave. It was conducted on 23rd of January via Zoom. Dr. Joy Manjila presided the meeting. Dr. Jithunath Chairman of IMA AMS, welcomed the gathering. Professor Dr. Roy Abram Kallivelli, Chairman of IMA AMS, he welcomed, he inaugurated the event, and the guest of honor was Dr. P. Gopikumar and Dr. Punyar BB convener. He introduced the faculty and the moderators. Dr. Nisha Nigil Harun from Wisconsin, she attended the meeting online and she was the main speaker. She talked on recover better long COVID-19 and diabetes. Dr. Shamir VK, Professor of Medicine at Kozhikode Medical College, moderated this session. Then IMA Thrissur, along with Anesthesia Society of Thrissur City, conducted a Republic Day ride on 26th of January. These are the pictures. This is the inaugural ride of riding club. This is the picture taken at Vilangangunda Amphitheatre. The bicycle ride started from Tekil.
സ്ലൈഡ് കാണാൻ പറ്റുന്നുണ്ട്.
Okay, hope now it's clear. So the bicycle ride started from Tekke Gobhiranada, Tekangad Maidan at 6:30 a.m. on 26 January to Vilagankum Hills. Dr. J. Chiman, Joint Secretary of IMA, Kerala State, inaugurated the IMA THRISSUR Riders Club at the Amphitheatre of Vilagankum Hills. Dr. Binil, Secretary of ISA, State Secretary, he inaugurated the ISA THRISSUR City Branch Riders Club. Dr. Joy Manjila, President, presided the meeting there. And Dr. C.V. Krishnamar, Master Rider, he spoke on the importance of cycling as a fitness program. We also served breakfast to the participants. Then this is the picture of the Republic Day flag hoisting at IMA House, Thrissur on 26 January. Flag hoisting was done by Dr. Joy Manjila, President of IMA, in the presence of Secretary and IPP Dr. Nivin, with Dr. Jain Chiman, Dr. Govindamuthi and other members of IMA Thrissur. So these are the pictures of the IMA Cultural Wing program. That was actually the New Year celebration on 26th of January via Zoom. It was inaugurated by the state president, Dr. Sankar, and Dr. P. Govikumar, secretary, was the guest of honor. Manoj Kumar, chairman of Culture Wing of IMA State, with the felicitation. Dr. Joy Manjila presided. Dr. Ravindra Verma, chairman of IMA Thrissur Cultural Wing, welcomed the audience. Dr. Nivin anchored the event. This is the picture of the IMA state meeting for the hunger strike organized by the IMA State Action Committee. It was organized on 28th of January, Thursday, via Zoom. IMA Thrissur President and Secretary participated in the meeting and they gave our valuable suggestions. And following that, we also attended in the district committee meeting, which was organized by
video.
Again, IMA Thrissur was very actively participated in the COVID vaccination scenario in Thrissur district. We attended the Thrissur district task force for COVID vaccination. We raised the issues faced by the IMA members regarding vaccine registration and the authorities assured regarding inclusion of the doctors who had not registered at that time. And they asked the pending doctors to get the data and submit it to the DMO office. And also during the meeting, there was a decision to increase the number of beneficiaries from 100 to 200 for faster vaccine coverage. Then on the National Girl Child Day, Women Doctors Week of Thrissur observed the National Girl Child Day by taking a class to the NSS unit of St. Mary's College. Principal of St. Mary's, Dr. Sister Maggie, welcomed the gathering, and Dr. Shobana Mohandas took a class for the students. Then IMA Thrissur, along with the DMO, organized a meeting for starting new COVID vaccination centers in the private sector for providing adequate vaccination coverage among the private doctors and staff. The meeting was on 31st January. About 100 representatives from the shortlisted private hospitals attended the meeting, and the new sites for in various parts of Thrissur district, it was decided, and it helped in increasing the vaccination rate in Thrissur. Then on the we observed the Anti-Leprosy Day 2021. There was a meeting in association with the Dermatology Club of Thrissur. Meeting was presided by Dr. Joy Manjila, then Dr. George Kurian, who is the president of IADVL, inaugurated and gave the inaugural address. IMA CGP chairperson Dr. Leela Braham welcomed the gathering, and Dr. Sharmila introduced the chief guest. We had Dr. Unnikrishnan, the president of the Dermatology Club of Thrissur, and Dr. N. Ashokan and Dr. Betsy Ambukan as the speakers for the occasion. Then we observed the Anti-Leprosy Day at the Gandhi Gram Hospital for Dermatology on 31st. The hospital is at Korti, and we distributed the snack packets to the inmates. Dr. P.S. Jithunath, President of Dermatology Club, joined the IMA THRISSUR team. We had Dr. Joy Manjila, Dr. Prakash sir, Dr. Nevin, Dr. Mukesh, Yaman sir, and our treasurer. They all attended the event at Berkeley. These are the pictures. On the same day was the pulse polio immunization program, and it was initiated at General Hospital Thrissur, and the first dose was given by the General Hospital Superintendent in the presence of IMA Thrissur Secretary, and also we travelled to various places for providing pulse for the polio immunization program. We went to Vadakunathan Temple premises, then we went to Municipal Bus Stand, and many other places, including the Taking Guard Maidan, for giving polio drops. IMA Thrissur participated in the KGM CTA hunger strike, which was conducted for their Shambhala Parishkaranam and allowances. We actively participated. The morning, myself and Dr. Jane Chiman from our branch, we attended their meeting, and we attended the inaugural function, and we provided our full support to them. And by evening, Dr. Joy Manjila, he attended the meeting, and you can see the pictures. Dr. Shamsad Begum and other members of KGM CTA, they were all present during the meeting, evening function. Now, this is the observance of World Cancer Day, IMA Thrissur with AMPOC on 6th of February. This was the World Cancer Day, the CME, and the CME was inaugurated by Dr. D.P. Gangadharan, the famous oncologist at Lakeshore Hospital, Kochi, and Dr. Joy Manjila, he presided the meeting. Dr. Pavan Thomas, Secretary of AMPOC, welcomed the gathering. Dr. Sharmila introduced the chief guest, and Dr. Anil Jose, HOD of Medical Oncology, moderated the CME. Dr. Meera Mohan, Clinical Faculty at Wisconsin, USA, talked on multiple myeloma state-of-the-art treatment. Dr. Midun Chako from Jubilee spoke on evaluation of cancer therapy techniques. And this was followed by a very lively discussion among our members. IMA Thrissur also participated in the inauguration of new cath lab at Government General Hospital Thrissur. These are the pictures of the new cath lab. The cath lab was inaugurated by Srimati K.K. Shailaja teacher. She was present at the Government General Hospital Thrissur, and she inaugurated the new cath lab. This is the picture of the second ride by IMA Thrissur Cycle Riding Club. The second trip was to Snehatira Beach, and there were about 26 riders. Now, coming to the Mixopathy hunger strike, IMA Thrissur very actively participated for the inaugural event. The first strike, which was conducted at Calicut, Dr. P. Govikumar, State Secretary, who is our branch member, then Dr. Nirmal Bhaskar, who is the Secretary of KGMCTA State Secretary, then myself, we all had attended the event at Calicut. There was a good coverage, and there was a very successful meeting. Then following that, our turn, the Thrissur district turn, was on 13th of February, and prior to that, we had conducted various meetings at branch level and district level. IMA Thrissur actively participated in the district committee meeting organized. These are the pictures. And during the meeting, Dr. Amarjyoti, chairperson of DC Thrissur, and Dr. Baiju, and the convener of Thrissur DC, they explained regarding the arrangements for the relay hunger strike at Thrissur on February 13th. And we had State Secretary Dr. P. Govikumar, who briefed on the situation at that point and the need for the protest, continuing the protest against the amendment. And we had our past presidents, Dr. Rashid sir, Dr. Deva sir, Dr. Sohan sir, they all expressed their views, and Dr. Jain Chiman also commented on the planning. Various specialty association members, including the dental association, participated in the meeting. These are the pictures from the Kottayam Nirahara Samaram. Myself and Dr. Jain, we attended the meeting. State President was there during the event, he inaugurated the function, and there were other senior leaders from the Kottayam branch as well. Again, we participated in the COVID vaccination district task force meeting. So at that point, so many doctors were left out from the registration. We made arrangements for the further registration, and also they assured there will be a mop-up round for the Covishield vaccine once the phase 2, which is going on right now, is completed. And the meeting was chaired by the district collector and the WHO officials as well as the DMO officials. Then prior to the day of our strike at Thrissur, on February 12th, we conducted a press club meeting at Thrissur. IMA Kerala State Secretary Dr. P. Gopikumar, he addressed the press club at Thrissur, and Dr. Amar Jayanti, Dr. Baiju, and Dr. Gio from IDA and myself were present for the press club meeting. These are the pictures of the IMA hunger strike conducted at Tekinkad Maidan. That was a very important day in the history of anti-mixophobia strike. Our state team representing the IMA Kerala protested at Delhi, and same time IMA Thrissur District Committee organized a very successful hunger strike at Thrissur. Dr. M. Menon, the State Action Committee Chairman, he inaugurated the strike at Thrissur, and around 20 members from various branches of IMA Thrissur District observed hunger strike. Members from all the branches, members from all other branches visited the groups in various time slots, and we had sister associations like KGMOA, KGMCTA, specialty organizations, dental organizations, and JD and MSL. They all extended their support and made their presence. Our venue was full throughout the time from 8 to 6, and we had many socio-political leaders like Anil Akira, MLA, then Sri Gunavardhanan, retired IAS, who was the Health Secretary of Government of Kerala, then Advocate Bashir from Lions Club, Mr. Anish from Janata Dal, Sri Venu, who is a political leader, a writer and thinker. They all visited and shared their views against our Ayush surgery, and we had a good team from IMA Thrissur under the leadership of our President Dr. Joy Manjila, who led the hunger strike at the Samarapanda. And by evening, the strike came to an end when Professor Anandageshwar sir provided Ilanir to our President Dr. Joy Manjila. These are the pictures. Other branches also very actively participated in the strike. These are the press reports. Then during the strike, we had leaders from Delhi and various other places, like our state president, state secretary, our past presidents, past state leaders, present state leaders from various locations. They addressed through Zoom. Then we had an IMA executive meeting on Sunday, 14th February, which was mainly to discuss the present situation of the IMA blood bank functioning. We had a business consultant who volunteered as requested by Dr. Abdul Aziz to study regarding the financial status and present functioning of IMA blood bank. During the executive committee meeting, we formed a high-power committee to decide on steps to save the blood bank from shutdown. And the committee, the executive committee decided Dr. K.C. Pravashan to be the chairman of the high-power committee for the blood bank, with Dr. Abdul Aziz, Dr. P. Gopinathan, Dr. Joseph John, and Dr. Pavan as the members of the committee. Further details of this will be briefed by Dr. Govindam Trizar. So these are the minutes and activities of the previous month of IMA Thrissur. Thank you.
ബഹുമാനപ്പെട്ട പ്രസിഡന്റ് ഡോക്ടർ ജോയ് മഞ്ജുല സുഹൃത്തുക്കൾ, നേരത്തെ ഡോക്ടർ പവൻ പറഞ്ഞിട്ടുണ്ട്, കഴിഞ്ഞ ഞായറാഴ്ച എക്സിക്യൂട്ടീവ് കമ്മിറ്റി മീറ്റിംഗിൽ ബ്ലഡ് ബാങ്കിന്റെ കാര്യങ്ങൾ വളരെ വിശദമായിട്ട് പരിശോധിക്കുന്നതിനും പരിഹാരങ്ങൾ നിർദ്ദേശിക്കുന്നതിനും ഒരു ഹൈപ്പവർ കമ്മിറ്റിയെ നിർദ്ദേശിച്ചിട്ടുണ്ട്. ഒന്ന്, ബ്ലഡ് ബാങ്കിന്റെ ജനറൽ ബോഡി നിർദ്ദേശിച്ചതോടെ അവിടെ ഈ റിട്രഞ്ച്മെന്റ് അധികമായിട്ടുള്ള ജീവനക്കാരുണ്ടെന്നും റിട്രഞ്ച്മെന്റ് നടപടി സ്വീകരിക്കണമെന്നുള്ള അതിനെപ്പറ്റിയുള്ള വിശകലനം. രണ്ട്, അവിടുന്ന് സാമ്പത്തിക റിസോഴ്സസ് ധനസ്രോതസ്സുകൾ ഉണ്ടാക്കുന്നതിനുള്ള മാർഗങ്ങൾ എന്തൊക്കെയാണ്, ബാക്കി ഏതെല്ലാം മാർഗങ്ങളിലൂടെയാണ് IMA ബ്ലഡ് ബാങ്കിന്റെ തനിമ നിലനിർത്താൻ പറ്റുക എന്നതിനെ പറ്റി ആലോചിക്കാനാണ് ഈ ഹൈപ്പവർ കമ്മിറ്റി രൂപീകരിച്ചിരിക്കുന്നത്. അവർ എക്സിക്യൂട്ട് ചെയ്യാനുള്ളവരാണ്. അവരുടെ ശുപാർശകൾ, നിർദ്ദേശങ്ങൾ എക്സിക്യൂട്ടീവ് കമ്മിറ്റിയിൽ അവതരിപ്പിക്കുകയും ആ നിർദ്ദേശങ്ങൾ സ്വീകാര്യമായത് എക്സിക്യൂട്ടീവ് കമ്മിറ്റി IMA ബ്ലഡ് ബാങ്കിന്റെ മാനേജിംഗ് കമ്മിറ്റിയിലേക്ക് കൊണ്ടുവരുന്നു. IMA ബ്ലഡ് ബാങ്കിന്റെ മാനേജിംഗ് കമ്മിറ്റി എന്ന് പറഞ്ഞാൽ ഡോക്ടർമാർ മാത്രമല്ല, ജില്ലാ പഞ്ചായത്തിന്റെ 3 ആളുകൾ കൂടി അതിനകത്തുണ്ട്. കഴിഞ്ഞ ദിവസങ്ങളിൽ ജില്ലാ പഞ്ചായത്ത് ഇലക്ഷൻ മറ്റും ആയതുകൊണ്ട് 2-3 മാസമായിട്ട് അവരുണ്ടായിരുന്നില്ല. പക്ഷെ ഇനി എന്തായാലും അവരുണ്ടായിരിക്കും. അപ്പൊ ഈ നിർദ്ദേശങ്ങൾ എക്സിക്യൂട്ടീവ് അംഗീകരിച്ച നിർദ്ദേശങ്ങൾ നമ്മൾ IMA ബ്ലഡ് ബാങ്കിന്റെ മാനേജിംഗ് കമ്മിറ്റി ചർച്ച ചെയ്ത് സ്വീകരിക്കുന്നത്. അപ്പോൾ ബ്ലഡ് ബാങ്കിനെ സംബന്ധിച്ച് ചില പ്രശ്നങ്ങൾ ഉണ്ട്. ധനസ്രോതസ് ഉണ്ടാക്കുക എന്നുള്ളതാണ് പ്രധാന പ്രശ്നം. നമ്മൾ ഒരു സാമൂഹ്യമായിട്ടുള്ള ചില പദ്ധതികൾ, കാരണം ബിലോ പോവർട്ടി ലൈൻ നമ്മൾ ഫ്രീ ആയിട്ട് കൊടുക്കുന്നു. ഒരു കാര്യം പറയട്ടെ, അതെല്ലാം ബ്ലഡ് ബാങ്കിനെ സംബന്ധിച്ച് ബാധ്യതയല്ല, അത് കാര്യമായിട്ടുള്ള കാര്യമാണ്. ഒരു മാസം ഏകദേശം 10 ലക്ഷത്തോളം BPL വിഭാഗത്തില് ഫ്രീ കൊടുക്കുന്നത് ചെലവാക്കുന്നുണ്ടെങ്കിൽ ഒരു കൊല്ലം നമുക്ക് 20 ലക്ഷത്തോളം ഗവൺമെന്റിന്റെ സ്ഥാപനങ്ങളിൽ നിന്ന് നമുക്ക് ഇത് പൈസ കിട്ടുന്നുണ്ട്. അപ്പോൾ പല കാര്യങ്ങളും ഞാൻ ഈ പറയാൻ കാരണം ബ്ലഡ് ബാങ്കിന്റെ എല്ലാ കുറെ കാലമായിട്ട് ഞാൻ മാത്രമല്ല അതിന് മുമ്പുള്ള ആളുകളും ബ്ലഡ് ബാങ്കിന്റെ കാര്യങ്ങളെ പറ്റി മീറ്റിങ്ങുകൾ പറയാറുണ്ട്. കാര്യങ്ങൾ ശ്രദ്ധിച്ച് അതിനെ പോകുന്നു എന്നല്ലാതെ ഗൗരവമായിട്ട് ആരും എടുക്കുന്നില്ല. ഒരു സർവേ നടത്തിയതിൽ ഏകദേശം 5 മുതൽ 10% ആളുകൾക്ക് ബ്ലഡ് ബാങ്കിന്റെ കാര്യങ്ങളിൽ താല്പര്യമുണ്ട്. അതാണ് ഏറ്റവും കാതലായ ഒരു കാര്യം. കേൾക്കുന്നു, അത് മറക്കുന്നു. പക്ഷെ ഇത് പ്രശ്നങ്ങൾ കൂടുതൽ ഗുരുതരമായിക്കൊണ്ടിരിക്കുകയാണ്. നിങ്ങളുടെ അഭിപ്രായങ്ങൾ മറച്ചു വെക്കാതെ കൂടുതൽ ഈ വേദികളിൽ പ്രകടിപ്പിക്കുകയും ക്രിയാത്മകമായി അഭിപ്രായങ്ങൾ നമ്മൾ സ്വീകരിക്കാൻ തയ്യാറുമാണ്. അപ്പൊ ഇത് എല്ലാവരുടെയും IMA തൃശ്ശൂരിന്റെ ഒരു പ്രോജക്റ്റാണ് IMA ബ്ലഡ് ബാങ്ക് എന്ന് പറയുന്നത്. അത് ലാഘവത്തോടെ എടുക്കാൻ പറ്റില്ല. അവിടെ ഡയറക്ടറുടെ കാര്യങ്ങൾ നടത്തുന്നതൊക്കെ ശരി തന്നെ. പക്ഷെ കാര്യങ്ങൾ ചില മാർഗനിർദ്ദേശം എന്തൊക്കെയാണെന്നുള്ളത് ഈ കമ്മിറ്റി നൽകുമെന്നുള്ള പ്രതീക്ഷയോടെ വിരമിക്കുന്നു. നന്ദി, നമസ്കാരം.
Thank you. Now I invite Dr. P. Govikumar, State Secretary. Dr. P. Govikumar. Hello. Dr. Govikumar.
Yes. Good evening. Welcome. Hello.
കേൾക്കാം സാറേ, പറഞ്ഞോളൂ.
കേൾക്കാം. അപ്പൊ എനിക്ക് പ്രശ്നം എന്റെ സമയമാണോ? ഓക്കെ. Good evening. Respected President of IMA THRISSUR, Dr. Joy, Secretary Pavan, past State President Dr. Govindakutti sir, senior IMA members and friends. ഞാൻ നാളെ സ്റ്റേറ്റ് വർക്കിംഗ് കമ്മിറ്റിക്ക് വേണ്ടി തിരുവനന്തപുരത്തേക്കുള്ള യാത്രയിലാണ്. അപ്പൊ അതുകൊണ്ട് ഒരു പക്ഷേ നെറ്റിന്റെ ചെറിയ പ്രശ്നം ഉണ്ടായി എന്ന് വരാം. വളരെ സന്തോഷമുണ്ട് ഈ IMA തൃശ്ശൂർ ജനറൽ ബോഡിയിൽ നിന്ന് പങ്കെടുക്കാൻ സാധിച്ചതിന്. ആദ്യമായി മിക്സോപ്പതിക്കെതിരെ നടന്ന സമരത്തിന് തൃശ്ശൂർ ജില്ലയിൽ നേതൃത്വം നൽകിയ തൃശ്ശൂർ ബ്രാഞ്ചിന്റെ പ്രസിഡന്റിനെയും സെക്രട്ടറിയെയും സ്റ്റേറ്റ് ആക്ഷൻ കമ്മിറ്റിയുടെ കൺവീനർ കൂടിയാണ് ഡോക്ടർ പവൻ. അതുപോലെ തന്നെ IMA തൃശ്ശൂരിന്റെ ഓരോ അംഗങ്ങളെയും മുക്തകണ്ഠം പ്രശംസിക്കുന്നതിന്, അഭിനന്ദിക്കുന്നതിന് ഈ സന്ദർഭം ഞാൻ ആദ്യമായി ഉപയോഗിക്കും. ഒന്നത്. രണ്ട്, വളരെ ശക്തമായ രീതിയിൽ തന്നെ ഒരു സമരം നടത്തുകയുണ്ടായി. തീർച്ചയായും അതിന് അതിൻ്റെതായ ഒരു ഇമ്പാക്റ്റ് ഉണ്ടായിട്ടുണ്ട് എന്നുള്ളതൊരു വസ്തുതയാണ്. പൊതുജനങ്ങൾക്കിടയിൽ, പബ്ലിക് ഫിഗേഴ്സിനിടയിൽ, അല്ലെങ്കിൽ സമൂഹത്തിലെ വ്യക്തികൾക്കിടയിൽ നമ്മൾ എന്തിനു വേണ്ടി സമരം ചെയ്യുന്നു, മിക്സോപ്പതിയുടെ അപകടങ്ങൾ എന്ത് എന്നതിനെ കുറിച്ചുള്ള ധാരണ പരത്താനെങ്കിലും അത് സാധിച്ചിട്ടുണ്ട് എന്നുള്ളത് വളരെ വ്യക്തമായി നമുക്ക് മനസ്സിലാക്കുകയാണ്. അതിന് പ്രയത്നിച്ച എല്ലാവരെയും ഒരിക്കൽ കൂടി അഭിനന്ദിക്കുന്നു. വീണ്ടും ആ സമരം നമ്മൾ തുടർന്ന് കൊണ്ടുപോവുകയാണ്. നാഷണൽ IMAയുടെ നിർദ്ദേശാനുസരണം വീണ്ടും ഇതുപോലെയുള്ള അവയർനെസ് സംവേദനങ്ങൾ അല്ലെങ്കിൽ മീറ്റിങ്ങുകളോ ഒക്കെ ആയിട്ട് ഇനിയും തുടർന്നു കൊണ്ടുപോകുന്നു. അതോടൊപ്പം പ്രധാനമന്ത്രിക്ക് നിവേദനം സമർപ്പിക്കുന്ന നാം എല്ലാം ഒപ്പിട്ടുകൊണ്ട് IMA മെമ്പർമാരും സാധാരണ ജനങ്ങളും അവരുടെ കുടുംബാംഗങ്ങളും ഒക്കെ മിക്സോപ്പതിക്ക് എതിരായി ശബ്ദിക്കുന്നു എന്ന ആ ആശയം, ആ സന്ദേശം എത്തിക്കുന്നതിന് വേണ്ടി സിഗ്നേച്ചർ ക്യാമ്പയിൻ നടത്തുന്നതിനുള്ള നിർദ്ദേശവും നാഷണൽ IMAയിൽ നിന്ന് ലഭിച്ചിട്ടുണ്ട്. തീർച്ചയായും അത്തരം കാര്യങ്ങളുമായി നാം മുന്നോട്ട് പോകുന്നു. അതുകൂടാതെ ഫെബ്രുവരി 24-ാം തീയതി ഒരു ഇന്റലക്ച്വൽ മീറ്റിംഗ് ഓൺ മിക്സോപ്പതി, അത് നാഷണൽ ഹെഡ്ക്വാർട്ടേഴ്സിൽ നടത്തപ്പെടുകയാണ്. പ്രശസ്തനായ ENT സർജൻ കൂടിയായ വളരെ പ്രശസ്തനായ ക്രിക്കറ്റ് കമന്റേറ്റർ ഡോക്ടർ പുരിയാണ് അത് മോഡറേറ്റ് ചെയ്യുന്നത്. അതിനകത്ത് സമൂഹത്തിനെ എടുക്കുന്നുണ്ട്. 24 അതൊരു ഹൈ പ്ലാറ്റ്ഫോമിലാണ് ചെയ്യുന്നത്. അതുപോലെ തന്നെ അടുത്തായിരിക്കും. അപ്പൊ അത്തരത്തിലുള്ള മീറ്റിങ്ങുകൾ കേരളത്തിൽ സംഘടിപ്പിക്കുന്നതിനുള്ള ചർച്ചയിലാണ്. നാളെ നമ്മുടെ സ്റ്റേറ്റ് വർക്കിംഗ് കമ്മിറ്റി നടക്കുകയാണ്. സ്റ്റേറ്റ് വർക്കിംഗ് കമ്മിറ്റിയിൽ ഇതിന്റെ കൂടുതലായിട്ടുള്ള ഹലോ അതിന്റെ ഇടയ്ക്ക് ഡിസ്കണക്ട് ആയി. അപ്പൊ നാളെ സ്റ്റേറ്റ് വർക്കിംഗ് കമ്മിറ്റിയിൽ ഇതിന്റെ ശരിയായിട്ടുള്ള ഒരു പ്ലാൻ ഓഫ് ആക്ഷൻ നാം സ്റ്റേറ്റ് വർക്കിംഗ് കമ്മിറ്റിയുടെ അംഗീകാരത്തോടെ ഒരു പ്ലാൻ ഓഫ് ആക്ഷൻ ഉണ്ടാക്കുന്നതായിരിക്കും. തുടർന്നും ഇത് മുന്നോട്ട് കൊണ്ടുപോകുന്നതിനുള്ള കാര്യങ്ങളാണ് ഇന്ത്യൻ മെഡിക്കൽ അസോസിയേഷൻ കേരള സ്റ്റേറ്റ് ബ്രാഞ്ച് ആലോചിക്കുന്നത്. ഒരുപക്ഷെ മിക്സോപ്പതിക്കെതിരായിട്ടുള്ള സ്റ്റേറ്റ് പ്രസിഡന്റും സ്റ്റേറ്റ് സെക്രട്ടറിയും നടത്തുന്ന ഒരു സന്ദേശയാത്ര, മെമ്പർഷിപ്പ് ഡെവലപ്മെന്റ് അടക്കമുള്ള സന്ദേശയാത്രയൊക്കെയാണ് നമ്മൾ ആലോചിക്കുന്നത്. അതിനെല്ലാം നിങ്ങളുടെ സഹകരണം ഉണ്ടാകണം എന്നും അതുപോലെ തന്നെ തൃശ്ശൂർ ബ്രാഞ്ചിന്റെ ആക്ടിവിറ്റിയെ സംബന്ധിച്ചിടത്തോളം നമ്മളിപ്പോ റിപ്പോർട്ട് ഓഫ് ആക്ടിവിറ്റീസും ഒക്കെ കണ്ടു. വളരെ ശക്തമായ നിലയിൽ, വളരെ വ്യക്തമായ നിലയിൽ തന്നെ ബ്രാഞ്ച് ആക്ടിവിറ്റി മുന്നോട്ട് പോകുന്നു. നമ്മൾ പതുക്കെ ഫിസിക്കൽ മീറ്റിങ്ങുകളിലേക്ക് പ്രവേശിച്ചു കൊണ്ടിരിക്കുകയാണ്. ഇപ്പൊ നാളെ നടക്കുന്ന സ്റ്റേറ്റ് വർക്കിംഗ് കമ്മിറ്റിയും ഹൈബ്രിഡ് പ്ലാറ്റ്ഫോമാണ്. കുറച്ചു പേര് ഫിസിക്കലായിട്ട് അവിടെ ഉണ്ടാവും. ആ രീതിയിലേക്ക് വരുന്നു. പിന്നെ വാക്സിനെ കുറിച്ചുള്ള ചില ആശങ്കകൾ കൂടി അതിന്റെ 1-2 കാര്യങ്ങൾ കൂടി പറഞ്ഞുകൊണ്ട് നിർത്താം. വാക്സിൻ രജിസ്ട്രേഷനിൽ ഇപ്പോഴും നമ്മുടെ കുറെ പേർക്ക് രജിസ്ട്രേഷൻ കിട്ടിയിട്ടില്ല. രജിസ്ട്രേഷൻ കിട്ടിയ പലർക്കും വാക്സിനേഷൻ ലഭിച്ചിട്ടില്ല. അപ്പൊ ഇതിന്റെ ഭാഗമായിട്ട് ഗവൺമെന്റുമായിട്ടുള്ള ഒരു ചർച്ചയിലാണ് ഇപ്പോൾ ആരോഗ്യവകുപ്പ് സെക്രട്ടറി ആയിട്ട് ആരോഗ്യവകുപ്പ് മന്ത്രിയുമായിട്ടും മുഖ്യമന്ത്രിയുമായിട്ടും. ചൊവ്വാഴ്ച മുഖ്യമന്ത്രി ഞങ്ങളെ ക്ഷണിച്ചിട്ടുണ്ട് ഒരു സംവാദത്തിനായിക്കൊണ്ട്. അപ്പോൾ തീർച്ചയായും ഒരു വാക്ക് ഇൻ വാക്സിനേഷൻ എന്നുള്ള രീതിയിൽ നിങ്ങൾക്കൊരു ഐഡന്റിറ്റി കാർഡ്, ആധാർ കാർഡും വോട്ടേഴ്സ് ഐഡിയോ കൂടെ കൊണ്ട് ചെന്ന് കഴിഞ്ഞാൽ ആരോഗ്യ പ്രവർത്തകർക്ക് നേരിട്ട് വാക്സിൻ കിട്ടാനുള്ള ഒരു രീതി ഓരോ വാക്സിനേഷൻ സെന്ററുകളിലും ഉണ്ടാക്കണം എന്നുള്ള ശക്തമായ ഒരു ആവശ്യമാണ് ഇപ്പോൾ നമ്മൾ മുഖ്യമന്ത്രിയുടെ മുമ്പിൽ വെച്ചിരിക്കുന്നത്. ആരോഗ്യമന്ത്രിയോടും ആ രീതിയിൽ പെട്ടെന്ന് ആരോഗ്യ പ്രവർത്തകർക്ക് രജിസ്റ്റർ ചെയ്യാത്തവരെ ചേർക്കുകയും രജിസ്റ്റർ ചെയ്ത് വാക്സിൻ കിട്ടുന്ന ആവശ്യകതയെ കുറിച്ച് ഊന്നി പറയുന്നുണ്ട്. പ്രത്യേകിച്ചും അടുത്ത മാസത്തോടുകൂടി പൊതുജനങ്ങൾക്ക് കൂടെ വാക്സിൻ കിട്ടുന്നൊരു അവസരമുള്ളപ്പോൾ, അല്ലെങ്കിൽ നമ്മൾ പലപ്പോഴും ഒരുപക്ഷെ കിട്ടാതെ പോകാനും സാധ്യതയുണ്ട്. അപ്പൊ ഈ കാര്യത്തിൽ കുറെ കൂടെ ശക്തമായ ഇടപെടലുകൾ ഇന്ത്യൻ മെഡിക്കൽ അസോസിയേഷന്റെ ഭാഗത്തുനിന്ന് ഉണ്ടാകുമെന്ന് പറഞ്ഞുകൊണ്ട് തൃശ്ശൂർ ബ്രാഞ്ചിന് ഒരിക്കൽ കൂടി അഭിനന്ദനങ്ങൾ അർപ്പിച്ചുകൊണ്ട് നിർത്തുന്നു. നന്ദി. ജയ IMA ജയ. ഡോക്ടർ ജോയ്. കാണാൻ പറ്റും. കഴിഞ്ഞു. താങ്ക് യു. യാത്രയിലാണ്, അതുകൊണ്ടാവും ഇടയ്ക്കിടയ്ക്കൊക്കെ ബ്രേക്ക് ഒക്കെ ഉണ്ടായിരുന്നുണ്ടോ. താങ്ക് യു.
Okay, now I invite Dr. K.K. Mohandas, Managing Director and of Elite Mission Hospital, Thrissur, and sponsors of today's scientific session for a few days. All the Dr. Mohandas.
Our beloved President Dr. Joy Manjila, Secretary Dr. Pavan, our Treasurer Dr. Joseph, and past President Dr. Niveen, senior colleagues, members of IMA THRISSUR branch, and friends. I'm really happy to be with you all to attend this IMA meeting. As you all know, we do not have regular meetings due to COVID-19 pandemic for the last few months. But I am happy that our branch, IMA THRISSUR branch, was organizing regular meetings at school level. And they have performed extremely well during this year. Last year also, our brothers performed very well. They have received various awards at state level and national level. And we have received the best birth award, the best brand award of state, and our president, Dr. Joy Manjila, he has received the best president award at national level. So I really compliment and congratulate the team led by Dr. Joy Manjila and also the Secretary Dr. Pavan and also the Treasurer Joseph George. State level.
State Secretary Award.
Okay.
State Secretary Award.
And I am also happy to say that our Secretary Dr. Pavan, he has received the Best Secretary Award at state level. Let us all compliment and congratulate them for their excellent performance during last year and also the way they are leading this club to make the heights of glory. Friends, today's academic session is hosted by Allied Mission Hospital. Our hospital has completed 42 years in the healthcare sector. They started with the minimal facilities where 20 beds and 2 departments. We have grown up steadily, adding more departments, more practice, and we have reached this level. Today, our institution is 50% multi-super specialty hospital with all the facilities and also major super specialty centers. To our credit, we have received ISO 9001 certification in 2003 and also the NIA certification in 2016. I'm happy that we are strictly following the guidelines of the ISO and NIA, which has resulted in improving the quality of healthcare and service in our hospital. Before I conclude, let me also thank all the members of IMA for the excellent cooperation and support we have extended to Allied Mission Hospital. Now, friends, today's academic session is hosted by Allied Urology. Even though our urology department was started a long time, the Allied Urology Center was started about 3 years back. We have expanded the department to most modern facilities like flexible cystoscopy, digital RIRS for kidney stones, and also we have introduced laparoscopy in cervical procedures. We have 2 consultants in this department, Dr. Jithunath and Dr. Anoop, and they are both are working as a team and they are producing excellent results. On behalf of the hospital, let me compliment them for their excellent performance. And today's topic for discussion is interpretation of urological tile marks in day-to-day practice. I'm sure that this is going to be a very useful and informative session in general practice. The time allotted is 40 minutes, 20 minutes for each speaker, and after that there will be an open session for discussion. In these 2 ways I conclude, and once again I thank the organizers for having invited us to the Thank you.
Thank you, Dr. Mohammed, for your presentation. Now I invite Dr. Pavan Madhusudan for the introduction of today's faculties.
Good evening. So let me take this opportunity to officially introduce today's guest speakers from Allied Mission Hospital. First of all, let me thank Allied Mission Hospital and Dr. Mohandas for helping us organizing today's scientific session for our general body. We have Dr. Anoop Shankar and Dr. Jithunath from Allied Mission Hospital. I think this is the second time they are coming here for as speakers for the general body of IMA THRISSUR. Let me introduce Dr. Anoop Shankar first. He's a consultant urologist and genitourinary laparoscopic surgeon at Allied Mission, and he heads the unit there. And he did his MBBS from AIDS Delhi, MS from Trivandrum, and MCs from Anoop. He is also a visiting consultant at Cooperating Hospital in Galapada, St. Joseph Shundal, Bishop Salapad Hospital, and Neem Care at Mala. He is also the treasurer of THRISSUR Urological present. Now about Dr. Jithunath, he is a urologist, andrologist, and retroperitoneoscopic surgeon at Allied Mission Hospital. He did his MBBS from Calicut, MS surgery and DNP from Trivandrum, and NCH genitourinary surgery from Trivandrum. He heads the endourology division at Allied Mission Hospital since 2017 till date, and he is visiting consultant at Cooperating Hospital in Galapada, Danya Mission at Kota, Vincent Depot Kollu, and Lal Memorial at Mapra. He is also a part of the first cadaver kidney transplant team in Kerala under the Mrudasanjeevani program, and he is also specially trained in main infertility and andrology. So with these words, I welcome both the speakers, Dr. Anoop and Dr. Jithunath, to the general body and scientific session of IMA THRISSUR. Thank you once again.
Thank you.
Good evening, respected senior doctors, my dear friends and colleagues. I am Dr. Anoop Sankar. Just to show my face once, because the mask may not.
You remove your mask and speak. It's not audible otherwise.
Zoom audible ആണോ? Zoom audible ആണോ?
Yes.
ഇപ്പോൾ audible ആണ്.
Audible ആണ്.
Zoom വരുന്നുണ്ടോ? സ്ലൈഡ് വരുന്നുണ്ടോ? കാണിച്ചേ വന്നിട്ടുണ്ട്. വരുന്നുണ്ടല്ലേ? ശരി.
Respected senior doctors, my dear friends and colleagues. I am Dr. Anoop Shankar, consultant urologist and surgeon at the Explication Hospital. And it is really a privilege to stand in front of you and share some interesting aspects of urology with all of you, which I'm sure will be a very interesting topic because it's a common things which like the patient asks you or sometimes will ask you some questions which are simple dilemmas which can be there in practice. So usually for any general practitioner, one of the commonest thing he or she will encounter is prostatic enlargement and prostatic hyperplasia causing bladder outlet obstruction. So, dilemma number 1. A 56-year-old, otherwise healthy gentleman has presented to me with hesitancy, intermittency, poor streak. Is it okay to start him on transfusation straight away, or should I investigate him further? So this is one of the questions asked by one of my friends. Most of the questions asked by my friends and colleagues.
അത് ചെയ്തിട്ട് മോരാക്കി കുട്ടിന്റെ മഞ്ഞ ഇതല്ല മോര് കൂട്ടാനല്ല മോരന്നെയാണ്.
Pavan ask everybody to
ഉപ്പിടില്ല അത് കലക്കി കഴിഞ്ഞിട്ട്
എല്ലാവരും മ്യൂട്ട് ചെയ്യോ? ആരൊക്കെ വീട്ടുകാര്യങ്ങൾ പറയുന്നില്ലേ? പ്ലീസ് മ്യൂട്ട് യുവർ ഫോൺ. പ്ലീസ്.
Sorry for the interruption. So all these dilemmas are actually questions asked by my friends and colleagues to me and Dr. Jithu. So this was the first question. So if the patient presents with LUTS, can we straight away start him on transfusion, or should we investigate him further? So the answer is, if the patient is presenting exclusively with obstructive LUTS, the LUTS can be classified into two categories, either boiling or previously known as obstructive LUTS, and storage, otherwise known as irritating LUTS. So if the patient is only having either hesitancy, intermittency, or poor stream, or need to stream, or post-void dribbling, you can, it's okay to start him straight away on transfusion and slowly investigate. But if he's having irritative symptoms, you should be more careful, because irritative symptoms means either the bladder is getting filled fast, or the bladder capacity is small, or there is bladder spasm. And the common causes for bladder spasm are: 1, inflammation. Commonest causes urinary infection. 2, damaged bladder wall. Commonest causes long-standing obstruction, usually due to prostate. 3, this malignancy. And 4, foreign body. Usually foreign body complexes, stents, etc. So the thing is, if there is storage symptoms, you should be more careful and you have to investigate it fast. Otherwise, you can start on transfusion and slowly investigate. What are the things you have to do? You have to get a DR done. A serum PSA has to be done to rule out malignancy. DR and serum PSA. Even routine should be done, and preferably do an ultrasound abdomen, specifically request for wrestling urine. As urologists, we will also do urophometry. Urophometry is nothing but an instrument onto which you can void, and the instrument will show you the rate of voiding, the speed with which you are voiding, and other parameters by which we can calculate whether the patient is actually having obstruction or not. So once you start the patient on transfusion, how long should we treat him? Initially, always review him back within a week or two, because if he is not completely relieved, you have to investigate further. There could be other causes. It may not be a VPH at all. It can be stricture, it can be stone. Many other possibilities are there. So if with transfusion there is no relief in a week or two, you have to investigate further. But if there is complete relief, then how long should you give transfusion? Well, it's a lifelong journey or till surgery. Why? Because see, transfusion is an alpha blocker. Transfusion, alpha-fusion, serotonin. These are all alpha blockers. What they do is actually relax the smooth muscle of the bladder neck. So they are actually not causing any permanent change to the anatomy or physiology of the prostate. So they will act as long as you give them. Once you stop them, we are back to square one. On the other hand, 5-alpha reductase inhibitors like finasteride and dutasteride will usually reduce the gland size. But the reduction will take almost 6 months. And a significant amount of reduction will occur only if the gland size is more than 40. So, if you are starting the patient on alpha blockers and 5-alpha reductase inhibitors combined, that is known as the first is known as monotherapy, and the other is combined treatment. If you are starting from a combined treatment, then after 6 months you can try stopping alpha blockers and just keep the patient going on 5-alpha reductase inhibitors. Some patients may still develop obstruction, but others can be maintained on 5-alpha reductase inhibitors. Can we treat all such patients medically, or would anybody need surgery straight away? See, the indication for surgery in BPH is one, if there is any structural damage caused by the BPH, like chronic urinary retention, upper urinary tract changes like hydronephrosis, significant bladder wall damage, changes, significant residual urine, recurrent stone formation, recurrent UTI. These are all indications for surgical intervention. So, even if at presentation you have such symptoms or findings, then of course you have to consider surgery for the patient. Again, another indication, if the patient is already on tamoxifen and Veracity, then that is an indication for surgical intervention. Acute urinary retention while on medical therapy, that's also an indication for surgical treatment. Why surgery for chronic retention, upper tract changes and all? The reason is surgery is the most effective way of correcting the bladder outlet obstruction rather than the medical management. So, when already damage has occurred to the body, it is not wise to continue on medication because the damage can worsen and things can go out of control. Now, there is another interesting thing. There is, in many ultrasounds, you might have seen this finding of IPP, there is intravesical prostatic protein, or a median lobe mentioned. So, what is this median lobe? Nothing, one of the adenoma is growing into the bladder. BPH adenoma is growing into the bladder like this, as you can see here. So, behind that, urine can stagnate. Then this can act as a flap valve. That is, when we are trying to avoid this, will come and obstruct the outlet. And it also changes the dynamics of void. So, although it is not mandatory to surgically treat all median lobe or IPP, medical treatment of IPP is quite often frustrating. The patient has a median lobe, the symptoms usually do not get relieved with medical treatment. So, that is also something which you can actually consider for surgery, although this is not an absolute indication. Now, to show you what a median lobe looks like, this is how a median lobe looks like. This is the picture taken from a digital flexible cystoscope. Actually, you can see here that flexible cystoscope is going in line with this, making a full U-turn, and then looking down at the median lobe from above, as you can see here. So, here this is the median lobe and this is the scope coming in, and this is the urethral orifice. You can see that this in this area behind the median lobe here, urine can stagnate, and this median lobe can fall forward and obstruct the outlet. This is the outlet actually. The scope is coming through the urethral orifice outlet. One word about the digital flexible cystoscope. This is the flexible cystoscope, and this is the rigid cystoscope. The rigid cystoscope was what was being used previously. The problem is it is a straight instrument, and if you do a rigid cystoscope, it will be usually painful. So, you usually would need anesthesia, and it cannot see all the areas of the bladder. With the 30-degree lens which we use, Normally, it is not easy to see this area of the bladder. Whereas in a flexible cystoscope, you can go in, see any part of the bladder. It is painless, relatively painless, does not need anesthesia. We do it as a daycare procedure. It's actually an office procedure. Just by the side of our OP reservoir, we can do it here. So simple. And we have completely shifted to flexible cystoscopy. Rigid cystoscopy we reserve for certain cases where rigid cystoscopy is mandatory. Other than that, we are doing all cases, we are doing only flexible cystoscopy, which that is the usual protocol in developed countries, and we are following the same protocol here also. This is our digital flexible cystoscope, an advanced machine which gives this privilege and makes the patient's life very comfortable. And I think we are one of the first to get it in Trissur. Now, this is chronic urinary retention. If the patient presents straight away with chronic urinary retention, we should consider surgery. Is it possible that a patient can directly present with chronic urinary retention without any preceding urinary symptoms? Yes, they can. Because if the obstruction develops very slowly, the bladder adapts and the patient may not know that he has a urinary problem till the bladder decompensates. So, as you can see here, as the bladder adapts slowly, the obstruction increases and the bladder damage sets in. This is the normal side, that's the normal side. This is how the damaged bladder looks like after slowly adapting. So, as the damage progresses, this is nothing but hypertrophy of the bladder walls, so that you can push the urine out easily. As the hypertrophy goes on, eventually the bladder will fail at one point of the time, when the patient will present with retention. So now, next dilemma. I have a patient in urethral colic and his ultrasound shows 6 mm lower urinary catheter. Can I try medical management? See, take this concept very clearly. If there is a urinary obstruction, anywhere, let it be in the ureter, let it be in the bladder, wherever, if there is a urinary obstruction, the first priority for anybody, including all of us, is to know whether there is an infection upstream to that obstruction. Because that is an emergency. It is something which can kill the patient. So, first thing you need to know is whether there is an infection proximal to the obstruction. So, always if the patient presents with a colic or a urinary retention, always ask whether the patient is having fever, chills, rigors, and better to get a total count, CRP, serum reaction. Because by assessing all this, you can know whether the patient is having any infection upstream. If there is an infection upstream, immediately refer to the urologist because it is an emergency. It's a urological emergency. It is something which can kill the patient. Because in obstructed system, the kidneys producing urine, the urine cannot go out. The pressure inside the kidney is building up. The only way for the kidney to relieve that pressure is to send the infected kidney back into the bloodstream or the lymphatics. So this gram-negative organism with the endotoxins being injected directly into the bloodstream, which will cause sepsis, septic shock, and dangerous consequences of that. So always make sure that there is no infection. Once you have made sure that there is no infection, you can go for a medical expulsive therapy, no problem. The principle of medical expulsive therapy is dilate the ureter, push the stone, reduce the edema, and give analgesia. The second and third point is pushing the stone and reduce the edema has now come into controversy. So we usually only follow the first and last. Dilate the ureter. We give tamsulosin or silodosin to dilate the ureter and give adequate analgesia. Usually the stone has to pass. Larger stones or more proximal stones may not pass. As the chance of an upper ureteral stone passing, even if it is a 6 mm size, is much lesser than a lower ureteral stone passing out spontaneously. Similarly, as the stone size increases also, the chance of spontaneous passing increases. So in those cases, it's better to consider ureteroscopy and lithotripsy. And ureteroscopy you can do in 2 ways. Either you can do a rigid ureteroscopy, which is usually the case in the lower ureteral stones. In the upper ureter stones, quite often when you do the ureteroscopy, stones might migrate into the kidney. So if you only have a rigid ureteroscope, it might be difficult for you to handle the case. One of the best advantages we have at our department, at the urology center and the hospitals, we are very accurate. Almost all the instruments needed are available at the hands. And so, even if the stone might have no problem, you put the flexible ureteroscope, pick it up, break it. So, for a ureter stone, you can use either a rigid or a flexible ureteroscope. Now, the next question is, I have a patient with chronic pain, but the ultrasound doesn't show the stone. It shows hydroureter necrosis and the lower ureter is obscured. Or another scenario, ultrasound shows hydronecrosis, no hydroureter, but there is no stone. What to do? See, in those cases, the recommendation is to get a contrast enhanced CT abdominal pelvis with urogram, provided the serum creatinine is not, that patient is not a renal failure. But mostly in the first scenario, that is hydroureter necrosis, the commonest cause is stone only. So you can sometimes get away with a late CT KUT without giving contrast. But you should consider other causes, which one is ureteric stricture, another one is papillary necrosis, especially in diabetic patients. Papillary necrosis is nothing but the renal papillae necrosis due to infection, and they fall into the ureter, causing ureteric obstruction. This usually patient will be presenting as infected hydronecrosis in sepsis, and it's an emergency. Usually, we have to send the patient immediately. Another cause is ureteric tumors. Like transitions and carcinoma of the ureter. Those patients usually will end up having a nephroureterectomy. Ureteric strictures, see, or short segment stricture, especially in the upper ureter, can be excised and anastomosed. Short segment stricture here, the upper ureter can be excised and the ureter spatulated and anastomosed over a distance. In the lower ureter, usually if it's a short segment stricture near the VUJ, you can disconnect the ureter just proximal to the structure and re-implant it into the bladder. But if the lower ureter structure is large, it's a long segment one, the ureter won't reach the bladder. In that scenario, you may have to use something like this. This is known as a Boyari flap. See, the bladder is opened like this along this lower line, and this flap is taken up to the ureter, healthy ureter. And then it is anastomosed to the ureter there, and then the bladder is closed here, stent is placed, and this part of the bladder, which is now the new flap, is tubularized. And the final product is ureter coming and joining this flap here. It's known as Boyari flap. I'll just show you one of our cases, one of our laparoscopic Boyari flap cases, which you've done. We are measuring the flap out in this, you can see, using a ureteric catheter. We mark the flap, and then here we are opening the bladder as per along the markings. And once the bladder is opened, then the flap is developed. We cut it like this, like this, like this. This would be, you can see the flap here. Now we cut here, and the flap is extended all the way till the ureter, and then the flap is anastomosed to the healthy ureter. Then a legal stent is placed across the anastomosis, and then the bladder is closed. You can see the bladder closure here. We are using a barb suture for bladder closure. Barb suture will hold on itself. You don't have to actually suture, not in the end. And here we are closing the, we are tubularizing the flap using a 30 wire. And once it is tubularized, after 3 weeks, we take a catheter out and do a cystogram. And this is the cystogram done at the end of 3 weeks. And you can see this is the bladder. The capacity has not decreased. Bladder adapts. even though you have taken a large amount of the bladder and made a flap, still the bladder adapts. And this part was the flap. This was initially part of the bladder. No, this was initially part of the bladder and is now bridging the ureteric defect. And this is the stent inside, and that's the kidney. Now, if there is only hydronephrosis and no hydroureter, the commonest thing you should consider is the pelvic junction obstruction. Other causes stricture. Pelvic junction obstruction is usually congenital, usually caused by a dynamic ureteric segment, PUJ segment, or a crossing vessel, and like this. So what we do is we exercise this unhealthy area, spatulate the ureter, exercise unhealthy area, spatulate the ureter here, and then anastomose it over the stent to the kidney. And this is one of our laparoscopic pyroplasty. This procedure is known as pyroplasty, and this is one of the laparoscopic pyroplasty. You can see the crossing vessel here. This is the crossing vessel. This is causing compression to the pelvic junction and causing the distension of the pelvis. You can see the distended pelvis. Now I am opening the pelvis here, and then I will dismember the ureteral junction. Then we will loop out the ureter from behind the crossing vessel. I am looping it out from behind the crossing vessels. Then the ureter is spatulated, this is spatulated ureter, and then a stent is placed up, anastomosis is done between the ureter and the healthy pelvis. And once the anastomosis is complete, you'll be able to see that the pelvis is completely collapsed and there is no further obstruction. Anastomosis is going on. And this is the final. See, this is the pelvic part, the right part right on the right side of the suture. This is the pelvis. On the left side, this is the ureter. The ureter is the normal hydronephrosis, and the obstruction is relieved. So, next diagram. It's a very common diagram because many people have asked. Patient is inflating urinary catheter is having a pericatheter leak. Increasing the size of the catheter has not helped. What to do? See, understand that an intact urethral sphincter would always hold around any size urethral catheter snugly and will not let the urine out. So then why will urine leak around the catheter? Because the bladder pressure is exceeding the sphincter pressure at some point of time. Why would the bladder pressure exceed the sphincter pressure? See, in a normal bladder, in a normally catheterized bladder, if you clamp the catheter, the urine will hold within the bladder, it won't come out by the side of the catheter. Because the sphincter is holding around, snuggling, fitting around the catheter. But if the bladder gets over-distended, really over-distended, to the extent that the pressure inside the bladder goes above the sphincter pressure, then it can leak. But this is not the common cause of pericatheter leak. This is a rare cause of pericatheter leak. Commonest cause of pericatheter leak is a bladder spasm. Bladder spasm will occur, as I already mentioned earlier, either in the presence of an inflammation to the bladder, like urinary tract infection, or the bladder is damaged because of long-standing obstruction, or there is a foreign body. We anyway have a foreign body here. The catheter itself is a foreign body. The foreign body itself can induce bladder spasm. Okay, so what to do? So these are the causes for the bladder spasm. What to do? In case it's the catheter block, you can flush the catheter. Take a urine culture, because it might be because of urinary tract infection. The bladder spasm is occurring because of urinary tract infection, and treat UTI. If there is UTI in the presence of catheter, you have to change the catheter. Reduce the amount of sterile water in the bulb. We usually put only 10 ml in the bulb. The more the sterile water in the bulb, the more the bulb is inflated, the higher chance for having a pericatheter leak. Many people think that it is the other way around. When there is a leak, we tend to increase the, put more sterile water into the bulb. No, that will only worsen the condition. because the more area of the catheter is now coming in contact with the bladder. So the bladder is exposed to more foreign body. There will be more bladder spasm. So always reduce the amount of sterile water in the bladder. Usually 10 ml is sufficient. And start the patient on bladder sedatives like zolifenacin, difenacin, oxybutynin, valproate, etc. That will usually take care of the pericatheter and increasing the size of the catheter usually will not happen. Next dilemma. A patient came to urinary retention, we catheterized and sent him home. Next day morning came back with hematuria. I'm sure we catheterized the patient properly and there was no hematuria at that time. When I heard this, we were also very sure that doctor catheterized the patient properly. There's no doubt about that. Because this hematuria is not caused by urinary injury. It's something else. The gist of the question should be like this. After catheterizing a patient with urinary retention, is it safe to send him back home always? No. Mostly it is safe, but not always. Why? See, the urinary retention, from the urologist point of view, there are three varieties. One is acute urinary retention. It is a painful retention of urine, and when you catheterize, immediately you drain less than 1 minute. Second one is chronic urinary retention, where you have a palpable bladder, but the patient is asymptomatic. And then you have an acute and chronic urinary retention, where you have a painful retention, and you catheterize, and the patient drains more than 1 minute. Why is this 1 liter cutoff? That's because otherwise healthy bladder, if you try to fill it, it won't expand beyond 1 liter. So if the bladder is expanding beyond 1 liter, that means there is some amount of chronicity. It has not happened over 1 day. It has happened over a long time. That is why it is known as acute on chronic, not an acute one. You can send the patient with acute urinary retention home. There is no problem after catheterizing. But if you send a chronic urinary retention patient or an acute and chronic urinary retention home, sometimes you can have trouble because there is something known as post-obstructive diuresis. In chronic and acute or chronic urinary retention, the body has slowly adapted to the retention over months and years. When this urine is thus suddenly drained out, the body struggles to get back to the new normal. And what are the problems? High urine output associated with hypertension, hyponatremia and other exploited anomalies. And sometimes the patient can have immediate hematuria. This is what was happening here. Okay, so he is lucky to have gotten away with just a hematuria. Things could have been still worse, much bad, like hypertension, hyponatremia, etc. So always, if the patient is having a chronic urinary retention or acute chronic urinary retention, never send the patient home. If the patient insists on going back, get it documented that only send the patient against medical advice. Never send him home on your own. Dilemma number 5. A 70-year-old gentleman came to patient with incontinence of urine. We catheterized him and noticed that large amount of urine is coming into the urobag. So if there was incontinence, why is he having so much urine held back in the bladder? If he was having incontinence, then why is so much urine coming once he catheterized? See, urinary incontinence basically means that the pressure inside the bladder is more than pressure which can be in the sphincter. So, in bladder spasm, you can have intermittent urge incontinence. When the sphincter is not very effective, not very efficient, you can have stress urinary incontinence. When the sphincter is fully damaged or the sphincter is bypassed, like you have an ectopic urethra, you can have continuous incontinence. But this fellow, the overflow incontinence is what is happening here, and it is something which we should always keep in mind, because overflow incontinence is something which is very detrimental to the kidney and bladder. It happens when the bladder is so much distended that the pressure inside the bladder equates that of the pressure produced by the sphincter. Now, any amount of urine added to the bladder will cause leak from the sphincter, from the urethra. This is a high pressure bladder. The pressure will affect the kidney, will damage the bladder. So, this is something which you should always keep in mind. So, whenever the patient with incontinence comes, always palpate the bladder, palpate for bladder. If there is a palpable bladder in the presence of incontinence, you have to refer into the urologist because it is something sinister. Now the dilemma number 6. I've been treating UTI with this patient for ages, but she keeps coming back with the same symptoms. I'm sure many of you would have seen this. Make sure that it is indeed vaccinated cystitis which we are treating, because there are so many other mimickers like genital TB, malignancy, foreign body, stones. Okay. Have I treated this patient with adequate dose of antibiotics? Dose of antibiotics should be adequate. Have I treated for adequate duration? Usually 2 to 3 weeks is required if there is recurrent infection. Okay, and if you suspect prostatitis, 4 to 6 weeks of antibiotic might be needed. Is there any predisposing factor? So you should evaluate your ultrasound and see whether any structural anomaly is there. Diabetes. So many other predisposing factors which has to be evaluated. Is the bacteria somehow protected from the antibiotic? There might be some, some foreign body or something, or a stone which can protect the bacteria from the antibiotic. So, best always get a urine culture sensitivity done whenever you are treating a patient of UTI, because it will tell you whether it is indeed vaccinated or not, which antibiotic to use, and whether this infection is a recurrent infection or persistence of urinary infection. So that is from me, and now Dr. Jithunath will take over from here. Thank you so much.
So now I thank Thrissur IMA for giving us a second opportunity to present before you. Actually, last time we came up with a few interesting surgical scenarios and surgical videos. Now we'll continue with the new innovations we started in our department. And this is a very common scenario, get an ultrasound with the standard calculus. The patient usually tells he is not feeling any pain. He is very comfortable because such a large size 8 centimeter calculus is not causing any pain. We will wonder whether we have to treat it or not, or just leave it behind. That's the question. Actually, why he is having no pain is because the stone is not causing any obstruction in his kidney. So, whenever there is an obstruction in the kidney, then only the patient will have the chronic pain. And but usually these patients have symptoms. They have fever, hematuria, high pain, but they usually overlook these symptoms. And occasionally they can come up with dangerous situations like septicemia, abscess, and all. So this is actually the staghorn stone, which is like the stag, like the deer with the stag, and we have multiple branches entering each calyces. Though it is a very large stone, the whole of the urine goes through the sides and it never causes such a severe dramatic acute colic pain. This is the CT picture showing the stone entering all the calyces. So the conventional procedure what's being done for long is the percutaneous nephrolectomy that we have been doing. So with the advent of the new techniques, last time we came up with the retrograde intravenous surgery using the flexible microscope. So we have modified it one step ahead. We came up with endoscopic combined intrarenal surgery, what is called ECIRS, which is the world standard for staghorn stones now, where a surgeon does the BCL part from above and endoscopic surgeon, RIR surgeon, assist him from below. So at a time there should be two consoles, two monitors for doing this. Now department we have excellent PCL surgeon Dr. Anoop, does it from above and from below I assist him and we will see the video on how I assist him in doing that. So at a time there should be two high definition cameras, and in Allied we have the great privilege of having two high definition cameras. So this is the video. The first part, this is what is happening is PCN. that is from Faculties nephrolithometrics gun. We have an excellent laser machine, which is a laser probe which is going inside. Stone is fragmented from above through a percutaneous tract which is placed. This is the usual conventional way of doing. Sometimes there will be, as you have seen, the scaffolds will be extending into multiple areas of the kidney. So all these areas are not accessible through the percutaneous route. In that situation, I can help you with this technique. This is the flexible scope going from below, and this is the view through the PCNL tract from above. So I am going to the upper calyx, basketing the stones to Dr. Anoop, keeping it for retrieval through the PCNL tract. So the advantage of this procedure is that 100% clearance. We can ensure 100% clearance, and the other thing is that doesn't need multiple tracks. Initially, usually conventional PCNL surgeons place 3 tracks, 2 tracks for PCNL surgeons. We usually put only single track, so the bleeding is very less, but we need a very good RIR surgeon and a PCNL surgeon for doing this latest innovative procedure endoscopic combined urological surgery. Coming to the diagram page, I think this is for pediatrician. I think the Faculties are get to hear this. And this is a WHO dictate that children are not eating adults. So we will come to the thing. This child actually presented to our casualty with he is a 2-year-old male child presented with acute pain. So initially suspected appendicitis, acute polyp. Ultrasound shows a left pubic abscess. Some of you may be worried that a 2-year-old baby is a 2-year-old child presenting with stone. Is it common? Actually, in our scenario, what we are the last 3 to 4 years in our census, in our studies, pediatric calculus is coming up. So, how to deal with these stones? Conventionally, what used to be done is a PCN. The other option is ESWL, but ESWL is out of favor now because of the complications related to it, and we are not sure whether it can fragment the stones. And even if it fragments the stones, it may be large chunks of stones which get obstructed in a small unit of this child. So, whether we can do the intrarenal, retrograde intrarenal surgery in a 2-year-old baby. Actually, we are one of the centers doing pediatric IRS in India. And for this child, we initially, as he came with acute pain, we stented the child with a small stent. We usually put a 5-front stent. In adult, we put a 3-front stent, a 16 centimeter short stent. Is available in our market. So we stented the child and repeated the culture was sterile. Then we did the procedure. And one other attraction of doing IRS is that very minimal radiation is only needed because only 2 X-rays that is needed. Before the procedure, we do a short of CR. At the end of the procedure, for confirming the stent position, we need a CR. All other things are done under visual experience. This is the pediatric IRS. We are going, this is a flexible scope. We have an endoscope. We are going through the ureter. This is the guide wire which we place to guide us into the kidney. Very tender ureter. It's not like an adult ureter. We have to be very cautious in doing an 2-year-old child with the stone IRS. We need a great kind of experience to it. This is the periureteric junction. We are going to enter that. And this is the, you can see some ragged areas here. This is the site where the stone has been stuck previously. You can see some ragged areas. Stone was impacted at that site previously. But now we have already stated as the stone has gone inside the kidney. We are entering the kidney. Yeah, that's the stone. You can clearly see the stone. And for this procedure, this time we have taken only single X-ray. That is very low compared to all the other procedures for pediatric stones. This is a stone, around 1 centimeter stone was seen in the mid-calyx. Now we introduce the laser fiber through a flexible scope. This is the laser fiber coming. This is what is called a pilot light to guide us whether the laser fiber is working and where it is coming in. We start slowly dusting it. And one important thing is that when we usually do an adult areas, we use pressure regulation. But in child we can't do that because it's a very soft kidney. We use only gravity regulation. And at the end, we could completely dust the stone. I will show you the. This is the stone. At the end, this is the guided place with complete clearance of the stone. Very few literature in the world. This is coming in the journal of urology, and we are going to publish this presentation. And this is very common scenario for a pediatrician. Child coming with a recurrent UTI. This child came to me around 1-year-old child with a recurrent UTI referred by a pediatrician. Which is she is a female baby. Because is normal. And but she's having a recurrent culture positive febrile episodes. In the last 4 to 5 months, we had I think 3 to 5 hospitalizations. We did an MCU. That's the value of doing this. We could detect an undetected reflex in the left side of the kidney. This is what is called the vesicular reflex. All of you may be knowing this condition. But sometimes it may go unnoticed. This is the mixurating cystourethrogram. When the child voids, the urine is going down to the urethra, but a part of it is reflexing through the left urethra into the kidney. And that was the actual cause of the recurrent UTI. Taking the MCU. Then, as there are different procedures for dealing with the vesicular reflex. One is the laparoscopic re-examination that usually Dr. Anoop does. But this is a very isolated reflex because it doesn't want a big procedure or a complex procedure done for a simple reflex. If you could stop this reflex with a simple endoscopic procedure, that is better. So we decided to do an endoscopy. This is a pediatric cystoscopy. This is the pediatric urethra, very soft urethra, and we can see this is the vesicular reflexing vesicular junction. We can see a wide mouth junction. We can see the normal vesicular, the normal one, and this is the reflexing urethra. You can see the mouth is wide open, and the other one have good valve in the right urethra. So the etiology behind vesicular reflex you may be knowing is usually due to the apparent development of the muscles around the vesicular junction. So we decided with injection of deflex. This is something called an injection endoscopic technique for vesicular reflex. This is a compound called dextranomor microspheres in hyaluronic acid. And once it is taken out of the particular temperature, that is set up within around 1 to 2 minutes. So we will get around 1 to 2 minutes time to inject just below the vesicular junction. Here we can introduce the needle, the different needle below the vesicular junction, and we are slowly injecting the deflex dextranomor material around the vesicular junction. You can see the bulbs coming up. The bulbs coming up. The advantage of this is that we can avoid a much complex laparoscopic procedure. It can almost be done as a daycare procedure. We need a short anesthesia. And the results are almost 85% success rate associated with deflex injection. The instruments need around, we need pediatric instruments for doing this particular procedure. So we have to wait around 30 seconds before we draw the scope because we are waiting for the deflex material which we have injected into the vesicular junction to set. Otherwise, what will happen is that if we withdraw the needle, the entire material will go out because it will take around 1 to 2 minutes to set. So once it is set, it will remain there. When we are taking out the needle, we can see a bulge there, that is the material we have taken, and this is the original vesicular junction. We can compare the old then it became a non-reflexive vesicular infection. So that is an excellent procedure, new innovative procedure. Already it has been there, but now for selected condition, pediatric conditions, we do this procedure. This is a very interesting case. It's about a tourist. Sometimes we occasionally get notifications. He actually he came for actually seeing Thrissur Puram before the COVID, and he developed a urinary infection at Thrissur. He was taken to another hospital, and he was diagnosed to have as Anoop told, a hypertrophic large median lobe, and already he has developed the features of chronic obstruction. And somebody, because those days there was so many WhatsApp videos about this prostatic artery embolization was going on. Somebody has told that, and he also feared about the a surgical procedure. Ideally, he has to go undergo surgery, but he is actually from Chile. His name was a big name, Oscar Esteban Kessler, around 79 years, and he underwent prostatic artery embolization from another hospital. And what happened is that he again developed infection of the procedure. So the problem with this prostatic artery embolization, lot of my colleagues, my classmates have asked about, and my friends even from IMA, they have asked about what is this prostatic artery embolization. This is actually a concept which is only in trial basis. It's not supposed to be done in a patient presently under the urological guidelines. We enter the prostatic artery and we embolize the prostatic artery. But that can be done only in very small prostates, not like this large prostates. If you do such a procedure in a large 154 cc prostate, this will happen. The patient will go again to urinary retention. So there are so many factors that should be considered while going for a procedure in a patient with BPH. So media and very people they present it like a very simple procedure. Prostatic artery embolization, just go there like a angiogram, you can do that. But there are lots of factors that should be considered while doing the prostatic artery embolization. And it is only in a trial basis. It's not being approved in India. And after that, I continued. He came with the bladder to Americas, continuously. And this is very happy smile. He told me like, you will come back next year. We will try to do a bipolar TRP. But we have excellent bipolar TRP machine compared to the old generation monopolar machine, which is usually done in other centers. The advantage of using this bipolar TRP machine is the current conductor will go through this lead, comes through this lead. Only in between the tissue gets charged. In all other monopolar PRPs, the conventional PRP done, the current will go through one lead, goes through the entire body, goes through the pad which is placed in the foot or and patient is sent to the current is sent to the ground. So what happens is that this current affects through the entire cardiac system. So if the patient with pacemakers, patient with cardiac problems, the best procedure is bipolar PRP. Another advantage is that the water PRP uses glycine for irrigation. The problem with the glycine toxicity is much. Here we use saline solution, and this is the advantage of using bipolar PRP. And we are not going to spare liver circumcision. And I think you have seen these videos from abroad. Pediatricians, pediatric surgeons doing scapular circumcision. So I think we are the first to introduce scapular circumcision in Kerala now. And this is very quick, safe, and a rapid recovery. And this is our first patient. This patient is a cardiac patient, high risk patient. He is on prophylaxis. He is on ecospirin. We did a scapular circumcision. I can assure that not a single drop of blood is spilled during this procedure. We can say that the donut of the prepuce is automatically cut out with the instrument, and automatically the scapula will